Let's get it.
Okay, I'm starting it right now. Oh, I gotta hide.
Hey everybody, welcome in. We're just gonna give it a couple minutes. Let everyone filter in. It takes a while sometimes when people are all waiting at the gate to pour in. Oh, he's broke 100. Still jumping. Okay. Couple minutes, everyone. Welcome in. Go ahead and use the bathroom, grab your drink of water, do whatever you need to do because we're gonna be going straight through tonight. And you guys feel free to do the Q&A, throw stuff in the chat. We will be doing Q&A. See Walter Ford. Hey, how's it going? We'll be doing kind of a Q&A. We'll be addressing some stuff. I'm going to kick this thing off here and then hand it over. Lots of good content, lots of good stuff. Okay. Let's go ahead and start. I'm going to go ahead and kick it off, and then that way, by the time I'm finished, our stragglers will be all loaded in. So first and foremost, everybody, my name is Beeben Russell. I'm here with the sponsor of tonight, Platinum Biologics, and the webinar is given to you and currently hosted by the IORE, the Institute of Regenerative. I always butcher it. You guys know it was on the invite. My point is, we are continuing our ongoing webinar and lecture series. This is our cash-based biologics. We've done a couple of these before, biologics below the knee, and we look at different types of applications below the knee. Usually this is leaning a little bit more towards the podiatrist and podiatry market, but I think what we have seen is we are now seeing multi-specialties racing to cash-based biologics. And I think a lot of the integrative clinics got a lot of hate, a lot of resentment, a lot of, hey, you're not qualified to be doing some of the things you're doing. And we've seen a lot of doctors, traditional doctors, we'll call them vanilla, right? Ones that typically don't want to be on the spear of innovation. Innovation is a spear, and a lot of people don't want to be sitting on the end of that point. And we understand that. But I think it's gotten to a point now where a lot of people have kind of, if you can't beat them, join them. Well, I think that's ringing true in biologics. We've seen now people charge these outrageous case fees in biologics, and it was kind of, you're going to charge a ton of money and go all cash, because if you didn't overcharge or charge a lot, or just basically turn your clinic into a sales room, you couldn't survive without insurance. That's not the case anymore. We're seeing more and more people, insurance is abandoning them. They are no longer abandoning insurance. It's getting harder and harder to run a practice based on just insurance in every type of profession. And specifically, one of the things that we really liked and what we tried to create was affordable biologics so that people that see high volume, it can actually make sense for them. They can actually not gouge patients. They can provide something that's extremely affordable, extremely effective, and make sure they don't feel like they're doing something that doesn't go along with them just trying to do what's best for the patient and to make sure they're getting the result. I think we've all seen a lot of change in this marketplace. And I think particularly when it comes to the podiatry market, wound care, we've got some things coming up here. No one knows for sure. I think November 1st, we're going to find out. But I think the point of this webinar is if you can bring on an additional $30,000 to $50,000 in revenue, if you can bring on 10, 15, $20,000 of net profit, I think it's the best, most strategic, and the best move that you can make for any practice right now. So, with that, I hope all of you are able to glean from this what is going on out there, what is capable in your practices. And if you have any additional questions, we can go over them. This is going to stick strictly to clinical application, financial, and everything else. I will say, I know some people want to bring up regulatory and everything else, and that's totally fine. We have two doctors on this call that have dedicated their time. They are experts in their field. So let's keep it clinical. If anyone needs regulatory or wants to talk to an attorney, that's great. We have attorneys. You can talk with them. We'll put you right on the phone with them. And hell, I think we should do an end of the year regulatory one. But I think it's good that we have two doctors on here. All questions, let's concentrate towards that. And with that, Dr. Bell and Dr. Martin, thanks guys for doing this again. You guys are, I think, a fan favorite of everyone out there. We always get the best kind of reviews on the duo of you two. So thank you so much for your time, your support, and the knowledge you're going to give us. Thanks, everyone.
Appreciate it, Baben. So just by way of introduction, I'm Dr. Scott Martin. I'm an interventional pain doctor, have been for probably 25 years. I serve as the head of the Outside Medical Advisory Board for Platinum Biologics. I've taken 14 papers to publication in the past 4 years. I talk to about 100 doctors a week, and it's my humble honor because I'm a needle jockey from, St. Louis, Missouri. I'm a country city boy with a sharp knife, right? But it's my humble pleasure to lecture here alongside Dr. Jason Bell, fabulous surgeon and podiatrist. And please, Dr. Bell, please introduce yourself.
Sure. Jason Bell. It's been fun working with Platinum and Dr. Martin. I've been interested in regenerative medicine for many years, and joining biologics and being part of this team has obviously heightened my awareness and my insight to the whole new paradigm of practicing medicine in a way that is more effective for our patients in many ways than traditional care and more beneficial to us financially. So it's been great. I've enjoyed it very much. And I've had a pleasure talking to so many, mostly podiatrists, the last roughly year, and just seeing everyone's eyes widen as I talk them through my practice and how these biologics and how Platinum has helped really change my practice. So I still practice somewhat traditional podiatry. I do all the meat and potato stuff, but a lot of the meat and potato stuff becomes applicable to biologics, and you can do better for your patients and yourself in instituting this type of practice. So it's fun. I love educating other doctors and helping them go further with their practice and spend less time, make more money, and get better outcomes for the patients. And I'm happy to help and be an adjunct to this lecture and anything going forward with Dr. Martin. It's a lot of fun.
Outstanding. So I tell a lot of stories, and we're going to start with a story, and then we'll get to this. All right. I'm going to give you two paradigms. I'm not going to tell you where this doctor works, but it was a colleague of mine. He was just crushing business. And he kind of went all in on the insurance game. And he's one of these guys that, if you gave him a puzzle, he could figure it out near immediately. And he treated insurance-based practice as a puzzle. Now, he's a pain doctor, and he had 3 surgery centers. He had 3 providers. And at the time that I first met him, his goal was to expand to 6 surgery centers and 6 primary providers with 6 nurse practitioners. And he kind of set them all up as independent little fiefdoms where the provider was given a lot of autonomy. He had a nurse practitioner, or she had a nurse practitioner that worked under them, and then he would support them with 2 medical assistants. At the time that I met him, his top earning provider, he was paying $1 million a year. His second most profitable provider, he was paying $780,000 a year. His third provider, because I only had 3 at the time, had only been out of practice for 2 years and was making over $400,000 a year. And I asked him, And this is 5 years ago. I said, is this really sustainable? And he's like, I've figured it out. I've figured the formula out. It's just a formula and I figured it out. I met him 2 weeks ago for coffee. And at the time, he was a heavyset guy. He was wearing a Richard Mille. He was driving a Bentley. He was just destroying cash. See him. He's divorced. He's lost 40 pounds. The guy looked like he'd gotten cancer. And about 2 years after I had met him, he had grown to those 6 clinics with 6 providers. And his physicians weren't making much more money because he'd essentially diluted his practice by taking what was a lock on his community and then building 3 additional surgery centers, hiring 3 additional doctors. So even though his providers were busy, they were still making $1 million and $780 and $450. His additional providers came on and were all making between $200,000 and $400,000. But his top dog wasn't happy, so his top dog left. When his top dog left and took his entire staff and his fiefdom, his number 2 guy left as well. Then his number 3 guy left. So now he's still running 6 surgery centers, but half of his staff is left. So has over half of his income because he was just managing the practice. At the time that his number 1, 2, and 3 left, he was deep in negotiations with venture capital. And as any of you know who've been acquired by venture capital, who have decided that you might want to sell out to venture capital, they tend to rake you over the coals. And that 7 times EBITDA ends up becoming about a 1.5 times EBITDA. And his wife divorced him. And he basically had to shut down all of his surgery centers and take a loss on all of those and just run 1 practice and go back to work at the age of 59. His number 1 guy left 3 weeks later, ended up having an affair with his office manager, and then he ended up going to jail because the office manager filed a horrific complaint against him for sexual battery and rape. His number 2 decided that a fast way to make more money was to sell narcotic scripts and also went to jail by trying to sell a narcotic script to an undercover DEA agent. Number 3 ended up having a heart attack. Now, conversely, I had a nurse practitioner that was an ER doctor, and she worked in a level 1 trauma center. And she saw on average 30 patients an hour. And any of you who are a podiatrist, and most of you are, you know what it is to see a crazy volume of patients in a small period of time. Most of you are seeing 60. Some of you are seeing 100 patients a day. She had these crazy shifts where she would have to triage up to 30 patients in an hour. She was getting paid an hourly rate at $140 an hour. Her health was declining. She felt terrible. I ended up talking to her on the phone. She'd always wanted to live in Coeur d'Alene, Idaho, and I helped her set up a practice in Coeur d'Alene, Idaho. And we built a model for her, just simply doing IV therapy. A year later, she sees fewer than 10 patients a week, and she's netting $30,000 a month. Now, you may say to yourselves, well, that has nothing to do with me. I'm a surgeon. That's true. But we're going to go through some numbers. And they may be uncomfortable numbers, but these are real numbers. $250,000 is the average amount of loans that any doctor or podiatrist takes to go through training. This is standard. Sometimes it's higher, sometimes it's lower. This $15 is your average net reimbursement for the top 3 procedures that you do. And you may say that's just not true, Dr. Martin, and I'm unfortunately going to tell you it is, because your top procedure that most podiatrists do is a plantar fascia injection.
Dr. Martin, and we just had a couple requests. I didn't want
Yep.
to clear flow earlier. Could you think you could bend the camera up just a little bit? People would want to see your face.
Oh, my apologies.
I'll tell you when to stop. Yep. Yeah, that should be good.
My apologies. Didn't
No,
know.
that's fine. Okay, go walk in front of it. I'll tell you.
All right. Do you want me to? All right. Can
It
this?
looks good. It looks good as is. Yeah, there you go. Okay.
Okay.
Cool. Yep.
My
keep going.
apologies. So plantar fascia injection number 1. What's number 2? Number 2 is actually Morton's neuroma. What's number 3? It's actually hallux rigidus. What's Medicare reimbursement for plantar fascia injection? $56. What about Morton's neuroma? About 48. What about hallux rigidus? About 52. So the average for all of these procedures is an average of $52 in reimbursement. The problem is you have to take 20% off that for copay because Medicare only pays 80% of this. And then the average overhead in a podiatrist office is 65%. So when you take 52 minus 20% minus 65%, you're netting $15 per case on the procedures that 1, 2, and 3 you do the most. Now, if you don't believe me, you can run these numbers with your office. And I had to do this in mine. Do you know how many procedures you have to do at $15 net to pay off student loans? Well, I did the math. At $15 a procedure, you need to do roughly 15,500 procedures. It's actually more like 16,000. You know how long it takes to do 15,500 procedures at even 30 a week times 48 weeks? You're looking at 10 years just to pay off your student loans, assuming you have no other debt. You're living in your office. You don't have a wife. You don't have kids. You don't need any food, right? You're just paying every dollar you make to pay off your student loans. Okay, well, you say, no, I do surgery. That's true. You do surgery. Let's do the numbers on surgery. What is the most common surgery done by podiatrists? The most common surgery done by podiatrists is a bunionectomy. Standard bunionectomy pays $500 minus 20% minus 65%. You're only netting $140 per case. Now you say, well, but I don't do just one, I'm doing like 5 a Friday. Okay. Okay. You get to the surgery center, 7 o'clock, you talk with the girls, they set up your first case, right? And say you have a smooth flow. All 5 cases go great. All right. At the end of the day, on those 5 cases, right? Even without your overhead, let's just call it straight Medicare reimbursement, you're only collecting $400 per case. So on those 5 cases, you made $2,000. But that $2,000 comes with a bit of a warranty. It's a 90-day warranty for your patients because now you have a global where you have to babysit those clients for the next 90 days. And any office visit, any dressing changes, anything that comes into your office, you get paid nothing for the next 90 days to make $2,000. Now, we haven't even factored in overhead. We're just talking about gross profit. You can't call it 500 because Medicare only pays you 80% of that. And now Medicare is probably one of our best payers. So we're going to present 2 scenarios. You have your bunion scenario where I'm going to make on average $400 and I'm doing 5 cases times $400, right? And I'm going to make my $2,000. Let's present a separate scenario and show you how this number comes into play. Instead of taking that patient to surgery because that patient failed steroids, and maybe they failed something like hyaluronic acid, and maybe they failed PRP. And we're not talking just bunion, right? Because some bunions absolutely need surgery, right? If we look at a scenario where we're using something like a Wharton's jelly, and there are Wharton jellies for $150. If we simply charge the patient $500, and on that $500, our net is $350. And just like our PRP, we run a series of 3. So we're making about $1,100, right? Sorry, $1,050, right? For that one patient. But I'm doing 5 patients, right? So on those 5 patients, I make a little over $5,000 doing 3 injections that takes you all 2 minutes. I see the same 5 patients that I operated on, and I make $2,000. I got to pay overhead on it, but I made $2,000. I see 5 other patients, and I put Wharton's jelly in a joint or an MTP. And I do 3 injections, maybe 0, 4, and 10 weeks. And on each patient, I make a clean $1,000. For that same 5 patients, I made $5,000, right? But you're not seeing 5 patients a week. You're doing 5 surgeries on a Friday, maybe 10, right? But you're doing 30 injections a week. 30 injections a week times an average profit of $1,000 per patient, just per patient, you're looking at $30K per week if you're doing that kind of volume. Now let's break it down in just simple, plain numbers. I'm going to make all of your lives easy. All right. The standard podiatry clinic sees on average 60 patients a day. In that 60 patients, let's say 10 of those patients come in for procedures. Your standard procedure is steroids. We know your standard reimbursement for that steroid injection from Medicare is $15. If those 10 patients ended up getting a biologic, and that biologic cost you $150, and patients paid $500, your net is $350 per patient. Well, in those 10 patients here, you make $150. And those 10 patients here, you make now, if I'm going to see 10 patients and I'm going to make $150 a week, I'm sorry, this is a day, or I can make that in a day. And believe me, there are podiatrists that are making this in a day, not doing wound care. This looks pretty interesting. Looks really interesting for a procedure that takes you 2 minutes. Almost all providers are moved by 2 things. 3, really. And the big 3 that moves providers is number 1, there's a great article over the weekend on this. Number 1 is a sense of purpose, right? I need to do what I do to make a difference. I want to dramatically benefit patients' quality of life. You can make money selling solar, you can make money flipping cars, flipping watches, you can make money doing lots of things, but that wasn't your calling. Your calling was to be a surgeon. Your calling was to stand for hours and hours a day, right? And help people simply walk. With one of the more noble professions in the world, because how many people actually have to walk to perform their job? Just about 80% of the population of the world. In order to really motivate people, right, it's got to make sense. Even if there's purpose, it still has to make sense. There's got to be a reason that you would do that. And at least when we're talking about doctors, it's got to make money. Because at the end of the day, all of us have overhead. All right? Now, we've talked about the money, right? And you all have your purpose. And so now what I'm going to do is I'm going to break it down and I'm going to make it make sense, right? And the way you make it make sense is you have to go to the science. Now, I am not here to lecture any of you on the science because you all know this. This is a cursory review. But I might open some eyes today, and I think that's a good thing. So let's make it make sense. That's our goal, right? We're going to take something like hallux rigidus. At the time, you and I, because I see pain patients that have hallux rigidus as well, are seeing a patient with hallux rigidus, all right? They have typically gone through first-line therapy. Dr. Bell, what's usual first-line therapy?
Typically, more often than not, if not oral NSAIDs and ice, a steroid injection.
NSAIDs is almost always first-line therapy, right? Second-line therapy is usually what? Steroids, right? Third-line therapy, not very common, but a lot of podiatrists like it a lot, right? And they're using PRP. It's not their kind of drug of choice, right? They're all like, you know, single barrel whiskey guys, and that got thrown out because all of you were used to using amniotic fluid because it reimbursed really well, but that's gone. Amniotic fluid's kind of like wound care, right? It reimbursed really, really well until it didn't, right? And so now you're kind of just left with what's left. Now, I said I was going to make it make sense. When we're looking at hallux rigidus, at the time that you all are seeing that joint, it's terribly important that we know what's going on at the joint level. At the joint level, what we have is we have collapse of articular cartilage. And this is going to be a common theme throughout this entire lecture. Articular cartilage. And articular cartilage is type 2 collagen. Most of you may know this, some of you may not, right? But our bodies do not classically synthesize type 2 collagen. They don't. As we get older, our bodies stop producing type 2 collagen. And the only predictable type of collagen that our bodies produce is type 1 collagen. But the articular surface of every large, medium, and small joint in the body is made of articular cartilage, is made of type 2 collagen. And our bodies don't synthesize it. Moreover, we don't get type 2 collagen in our regular diet. The American diet does not contain type 2 collagen. You're not eating it, I'm not eating it. How many of you had bone marrow for breakfast today? Probably none. So if our bodies don't make type 2 collagen and we're not consuming it, how do you get it? Well, therein lies the rub, and why the majority of Americans suffer from degenerative joint disease. Because that very articular cartilage is in our knees and our hips and our shoulders, but also in our big toe, right? In the subtalar joint, as well as around every single bone of the foot. And that articular cartilage is subject to internal and external stresses that tend to down-regulate the body's production of that cartilage. We're going to go through this very, very quickly. The natural history of cartilage-based degeneration is as follows. First, you get fibrillation. of the articular cartilage. Fibrillation means due to stress, variable stress and pressures through the joint, you get cracks in the articular cartilage. After those cracks happen in the articular cartilage, the initial response is an anabolic response by the chondrocyte. That anabolic response by the chondrocyte upregulates COL2A1, SOX9A, and ACAN, or aggrecan. But this is very transient, because with persistent stress, that anabolic chondrocyte changes to a catabolic phenotype. With a catabolic phenotype, we end up getting a predominance of IL-1 beta. We get a predominance of IL-6. We get a predominance of TNF alpha, which now brings inflammation into the joint and starts to downregulate COL2A1, SOX9A, and ACAN, and starts to break down the joint. The reason I present this natural history for type 2 collagen is very simple. What do NSAIDs do? NSAIDs work on COX and LOX activity. And even though they are an anti-inflammatory, the COX cascade that they induce down regulates COL2A1 and SOX9A. And I'll provide the literature at the end of this. We'll give you a link to this wonderful handout that will show you all this literature. NSAIDs actually impair the production of type 2 collagen. Most probably don't know that. What is our second line for something like hallux rigidus? Well, steroids, right? Systemic steroids, Medrol dose pack, prednisone, or injectable steroids. Would it be a shock to you if steroids also worked by way of COX inhibition and steroids also down-regulated COL2A1? Well, it shouldn't be, because they do. So is it possible that we're going for a trifecta here? Again, I'm a simple guy from southern, Missouri. I'm not the brightest guy in the room. I'm never going to be. But for me, things have to make sense. Well, when we use something like PRP, we're not using amniotic fluid anymore. Nobody pays for that. So we're using PRP. Now, if I go on ChatGTP or ChatGTP, whatever, if I go on Chat and I look up PRP and I say, well, does PRP induce anabolic or catabolic activity of the chondrocyte? What Chat will tell you is that it's actually a good thing, that it stimulates collagen. Herein lies the problem. If you don't know how over 95% of providers are making their PRP, you don't know that most providers, 95% of them, are using PRP that actually is causing a catabolic down regulation of COL2A1. Because in order for PRP to be anabolic, you have to use a red blood cell sparing kit. You have to have double spun PRP, and it has to be leukocyte poor. Now, what percent of doctors are using RBC sparing kits, double spun centrifuge, and leukocyte poor PRP? Fewer than 5% of providers in the country. Most of you are taking the kits that you're buying for between $250 and $450, putting it in the centrifuge, hitting the button the way they told you to hit it, drawing it off and injecting. And unfortunately, when you're doing that, you have what is called a pro pro-inflammatory cascade. That pro-inflammatory cascade happens because your red blood cells in 3 days release heme and iron. When your red blood cells release heme and iron, what do? They activate excitatory amino acids. And the excitatory amino acids, glutamate, aspartate, calcitonin, and G-related peptide, do what? They upregulate IL-1 beta. They upregulate IL-6. They upregulate TNF-alpha. They actually stimulate catabolic inhibition of COL2A1 and SOX9A, and they break joints down. Now, was it a surprise to me when I found out that Big Pharma's pushing NSAID steroids in, according to the FDA, PRP is just also great, right? No regulatory hurdles around PRP, but that all three of them are catabolic in nature and break a joint down? Wasn't a surprise to me. I'll say that. So what do I do instead, understanding that this is what happens? I'm not going to erase this. I'm going to erase this so that we can present the counter opinion, right? What I tend to use is an umbilical cord derived tissue. Now, most of you doing wound care are used to something like an amniotic dehydrated allograft. Right. That allograft itself has similar properties to Wharton's jelly. And the properties that make it similar is that amniotic membrane has type 1 collagen and type 3 collagen primarily. It also has a bit of type 2 collagen. Wharton's jelly, similarly, is type 1 collagen, type 3 collagen, and a bit of type 2 collagen. Further, Wharton's jelly is immune privileged. Because it's immune privileged, it actually down regulates inflammation. If we look at PRP, standard PRP works by way of an M1 macrophage pathway to upregulate TNF-alpha, upregulate IL-1 beta, upregulate IL-6. What does Wharton's jelly do? Something exactly like your dehydrated amniotic membrane allograft for wound care. You know, if you stick a skin sub on a wound, the inflammation goes down. Healing starts to happen, right? We can use it as a barrier or covering, but by and large, at a physiologic level, we know that wound heals. But does the same thing happen if I put Wharton's jelly into a hallux rigidus joint that's got lots of inflammation in there? As a matter of fact, it does. Because Wharton's jelly and amniotic membrane work by way of an M2 macrophage pathway, where they upregulate IL-10. They upregulate ARG1. That's a G. And they downregulate IL-1 beta. That has a net and a very potent anti-inflammatory effect. So if I was to do this for hallux rigidus, the standard of care for 25 years, 30 years, has been NSAIDs, catabolic, followed by steroids if that didn't work, catabolic, followed by PRP if that didn't work, catabolic as well. Which means that that patient with hallux rigidus now gets the traditional, hallux, varus with metatarsus valgus, right? And then you got to chop. Because in this scenario with hallux rigidus, right, once we start to get that alignment, no injection of anything is going to change a malalignment. But persistent inflammation, and now that we know hallux rigidus is inflammatory, nice paper published, I believe, 2 years ago, looking at the inflammatory nature of hallux rigidus. because there's progressive inflammation, because there's progressive breakdown of the articular cartilage, and because, we have women out there, it's not lions and tigers and bears, oh my, it's kind of Louboutin and Gucci and I don't know, Stella McCartney, oh my. They're wearing these 7-inch heels with all of that downward force on the first digit. So it's no wonder that they're getting hallux rigidus followed by a bunion. But ultimately, that bunionectomy is paying you how much? It's paying you $400. That's not net. That's what you're getting from Medicare because that procedure only pays $500, less 20%, right? And then after we take our 65% overhead, we're really only making $140. Well, what if we could prevent 90-day global and $140 net by using something that makes a heck of a lot more sense and applying a Wharton's jelly product? I said when I started that I'm just a simple guy. And if it doesn't make sense, I just don't do it in my practice, right? We started with hallux rigidus. So now let's make it make sense for more of what you're seeing in your practice. And let's stick to our 3 paradigms, right? We got purpose, right? We have money, right? And then it's got to make sense. So let's stick to those 3 paradigms through this lecture. And now let's address plantar fascia pathology. All right. Now, we know from a landmark paper published just last year that the majority of plantar fasciitis isn't actually a fasciitis at all. It's actually plantar fasciosis. It's not inflammatory. It was a wonderful paper, right? But about 80% of our patients that we're diagnosing with plantar fasciitis don't have any inflammation at all. Now, we're not talking about breaking down type 2 collagen, but can you break down the balance of type 1 and type 3 collagen in the plantar fascia if you're using things that cause more inflammation? Sure you can, right? Now, NSAIDs, none of you are doing plantar fascia injections because NSAIDs work. Most of you have abandoned steroids because we know that steroids are catabolic, and with repeated steroid injections, we run the risk of rupture of the plantar fascia. This is commonplace, right? So it's not necessarily down-regulating COL2A1, but we're ending up with, at times, catastrophic pathology wherein we're rupturing plantar fascia. Now, I don't know about you, but if you've ever injected PRP into the foot of a patient with a 22 gauge needle, because you can't push PRP through a 25, or at least it's really, really hard. Maybe you can get it through a 23, right? But by and large, you're pushing that PRP through a 22 gauge needle. And when you slam a 22 gauge needle into the plantar fascia of a patient, as happened to me, the only time I've ever been hit in 25 years of medicine, I've had guns pulled on me, knives pulled on me, but a little old lady came into my office and she'd failed cortisone and she'd failed NSAIDs. And I said, I got the magic for you. And so we drew her blood and I spun it down and I used my cold spray because I didn't want the lidocaine to denature my biologic. And I hit her plantar fascia with that 22 gauge needle. And as I started to push that PRP, she swung on me and I barely missed getting knocked out. And she still caught me on the nose, the edge of the nose. And I got all teary eyed and my nose ran, but she didn't break my nose, thank God. And boy, was she hot, because this hurts. It's got a pro-inflammatory response. And so when you slam 4 or 5 cc's of volume through a 22 gauge in the bottom of somebody's foot and it hurts already, right? This is very painful and it takes up a lot of space. Now, this is just plantar fascia. I'm not talking about burying the needle all the way down to the spur and dropping it around the spur and then redirecting and dropping it in and around the plantar fascia. Now, I mean, you need to hold somebody down with one of those like papoose things because, I mean, they're coming at you. So if this doesn't make sense, and this is what we've done for years and years and years, what might make sense? In particular, since we're really talking about plantar fasciosis and not plantar fasciitis. Well, what might make sense is to use a Wharton's jelly product that we know is type 1 and type 3 collagen, right? And when we put in a product that is a balanced amount of type 1 and type 3 collagen, and you can push this product through a 31 gauge needle, you can use an insulin needle and push this product, right? It's not inflammatory. It's got type 1 and type 3 collagen. And we're talking about a collagen-based defect anyway. Because when I put my ultrasound on this, what do I see? I see hypoechoic areas. I see dropout of collagen, dense irregular tissue, which is type 1 and type 3 collagen. So does it make sense to put in a growth factor complex that's predominantly type 1 and type 3 collagen? It does. But you remember that we talked about what everybody used before down here, right? Amniotic fluid. Everyone was really excited about amniotic fluid. Why do people use amniotic fluid? Well, they used amniotic fluid because it had an anti-inflammatory effect. What was that anti-inflammatory effect predicated on? It's actually predicated on hyaluronic acid because there's a fair concentration of hyaluronic acid in amniotic fluid. And hyaluronic acid downregulates inflammation. What concentration of hyaluronic acid do you think exists in Wharton's jelly? Well, it just so happens that the hyaluronic acid in Wharton's jelly is 100 times that of amniotic fluid. 100 times. So not only do we supplement the cartilage-based defect, but we also have a mild anti-inflammatory response because there's incredibly concentrated hyaluronic acid in Wharton's jelly. And so does this make sense? You betcha, right? We don't ever want to take this patient to surgery. We don't ever want to have to do anything with this because it's a nightmare. Last thing we want is them to rupture their plantar fascia and then have to take them to surgery and try to reattach it. It's a horrible surgery. Dr. Bell, what's that surgery like? How long does a plantar fascia reattachment usually take if it ruptures? I lost him.
Dr. Bell, sorry, you're Dr. Martin, you weren't seeing him. You're on mute.
There we go. So a fasciotomy will take an active person, a runner, a pickleball player. They're out at best case scenario. I tell them they're back to full-fledged activity at 4 months, and that's best case, which I don't like to tell my patients because then the expectation is a little too rigid. So I tell that patient 5 to 6 months until they're running again. It's a big turnoff, and that's why in my practice I end up using a lot of biologics, and surgery is an absolute last case scenario now. And it's
how much do you get paid for that fasciotomy?
We get paid less than a bunion for a fasciotomy. We probably get paid $450 for a fasciotomy. So not only is it the least favorable option for the patient, it's the least favorable option for the provider as well. So it's a non-starter in my practice unless we get there. And once in a while we'll get there. But they're going to hear about this first, and most will be interested in pursue the biologic.
You're making a little under $100 for that fasciotomy, right? How long does the fasciotomy take?
It's a quick procedure. Most good surgeon will do it in 20 minutes. But then, like you spoke about, then you have 90 days. You have dressing changes. You have office visits. You may have some complaints. You could get a post-surgical infection. And you got fidgety patients who in your office, as we all know, whoever's watching, when you tell them, Mr. Smith, it'll be 4 or 5 months until you're playing pickleball, and he's nodding his head, yes, he gets it. Or Miss Smith, it's 4 or 5 months at least until you're back to running, and she's nodding her head. When they're going through it, and it's 4 or 5 weeks out, and they can still hardly walk, they're starting to get frustrated. And when it's 2 months out, and they say, Dr. Bell, I still can't even come close to running. And we tell them, Miss Smith, I told you it would be 4 to 5 months. I told you this. No, you didn't. No, I know I told you this because I tell everybody this for 22 years. It's easy to say yes beforehand, but now that you're in it, it's very frustrating. So we all know for these reasons, these recoveries are pretty brutal. And if there's another way, it has to be pursued.
So does it make sense to operate these people? In all honesty, it really doesn't, because if that patient is out for 4 or 5 months, even if they do recover eventually, right? They've complained to everyone they know about you for 4 or 5 months and told everyone they know, everyone, mother, brother, sister, cousin, person next to them at Starbucks, person in line with them at the DMV, how awful a doctor you are, because you never told them that it was going to take 4 or 5 months for them to recover. You never told them they had to be out, off pickleball. And now they've lost their rank, right? And they're no longer a 4-0. Now they're a 3-5. And now they have to build their rank up again and all of this, right? Golfers are worse, right? Their handicap goes to hell. This just makes more sense, right? Now, I didn't get into any specific anatomy, but I'm going to do that just briefly because we're going to dive in a little bit deep on just some of the practical applications you can use this biologic for. And in order to understand that, we have to start with the basics. Now, the basics are, we have mom, right? Here's mom, right? And she's got her belly and she's pregnant, and here's baby, right? Now, it's not the best mom. Sorry, guys, right? Umbilical cord itself is on average 28 centimeters long. Now, there's an epithelial layer to the umbilical cord, and inside there are 3 vessels. And surrounding those vessels is a primordial tissue. And that primordial tissue was discovered by Dr. Wharton in 1950. And that, my friends, is Wharton's jelly. Now, we already said that Wharton's jelly is unique. It only exists in the umbilical cord of mammals. Wharton's jelly is what, right? Well, number one, it has robust extracellular matrix. What is extracellular matrix? It's the microarchitectural scaffold. It's responsible for keeping our bodies together. It's in every bit of dense irregular tissue. It's in muscle. It's in everything, right? Wharton's jelly also has type 1 collagen, type 3 collagen, like we said, a little bit of type 2 collagen, hyaluronic acid, has differentiated mesenchymal stem cells, has exosomes, has glycosaminoglycans, proteoglycans, right? And regulatory cytokines and chemokines. All of that is in this tissue. Now, this tissue is also immune privileged. And if you were curious, COVID vaccine spike proteins do not cross the placental barrier because they can't. And so what we're talking about is something that's not going to cause inflammation, that has a robust amount of collagen-based growth factors, has hyaluronic acid, exosomes, mesenchymal stem cells, all of these other goodies. It's immune privileged, and the COVID vaccine doesn't affect that tissue. That is a pretty robust substance, right? Now, when we talk about potential applications, the most commonly used product for podiatrists is a lyophilized Wharton's jelly. That lyophilized Wharton's jelly is something called nano DPM. It is 100 milligrams of Wharton's jelly. It is shelf stable for 3 years. Simply reconstitute this with 3 cc's or 4 cc's of normal saline. And what can you apply this product to? Well, we already said we can use it for plantar fascial paradigms, right? What else could we possibly apply this for? We already said we could do it for hallux rigidus. Can you put it in a bunion? Yes. Have doctors done it? Yes. Early, not late, right? What about subtalar joint degeneration? Of course. What about medial ankle sprain, lateral ankle sprain? What's the deltoid ligament? Well, the deltoid ligament is dense irregular tissue. It's type 1 and type 3 collagen. What about the ATF? What about the calcaneofibular ligament? Also dense irregular tissue, right? What about the Achilles? Of course, type 1 and type 3 collagen. What about intersubstance tears of muscle? Pick your pleasure, right? We have peronei, we have the posterior tibialis, we have the gastrocsoleus complex, right? We have tons of different muscles that we end up seeing with tears in them. The tears in that muscle usually tear at the musculotendinous junction. That musculotendinous junction, that intermediate zone between muscle and tendon, is dense irregular tissue. And the most common source of a tear is at that musculotendinous junction. So is it appropriate to use a product that has dense irregular tissue that's type 1 and type 3 in a region of a tear of collagen that's type 1 and type 3? You betcha. Now, gets a little more interesting. Can you use this product, which is type 1 and type 3 collagen, for something like a neuropraxic deficit? Well, what do we know to be neuropraxia? Well, we know Morton's neuroma, we know tarsal tunnel, and we know perineal neuropathy are all pathology of dense irregular tissue. And you may say that's not true. Well, let me show you how it makes sense. Every nerve actually has 3 different layers. There is an endoneurium, there is a perineurium, and there is an epineurium. The epineurium around the nerve is dense irregular tissue. We're all familiar with the fact that most nerves are myelinated. That myelin only heaps up on scaffold, on dense irregular tissue. Without scaffold, you do not get myelination of a nerve. And we know information travels. It travels by jumping internode to internode down the nerve by way of what we call saltatory conduction. Kind of like driving from Las Vegas to LA, jumping every 10 cars. You're going to get there much faster. A neuropraxic deficit, by definition, is damage to the epineurium. And the epineurium is dense irregular tissue. So when you see a patient with Morton's neuroma, the most common cause of that is a neuropraxic deficit of that interdigital nerve between the 4th and 5th metatarsal. Neuropraxic deficit of the tibial nerve as it dives under the tarsal tunnel before it breaks into its 3 branches, the calcaneal, the medial, and lateral plantar branch. that initial tingling, numbness, tingling that we see in those patients that are very pronated, right? Where they start to get tarsal tunnel just due to the torque and the stress across that fibrous ligament in that bony canal is a neuropraxic deficit. That pathology of the perineal nerve, when people cross their legs and they like twist that leg under that one, I can't do it. And they end up getting pressure just distal to the fibular head, and they end up causing a neuropraxic deficit to the superficial perineal and the deep perineal. Can you apply a biologic that is a little bit anti-inflammatory because of its hyaluronic acid, but mostly a type 1 and type 3 collagen to that collagen-based deficit? You can. Clinically, do patients do better? You betcha. They do a lot better. Specifically speaking to neuropraxic deficits, I've had a clinic in Branson, Missouri, who has been doing a very, very wonderful observational study. Now, their goal was to collect data on over 250 patients. I believe they're somewhere in the 200 range now. They've been collecting data now for a little over 2.5 years. And what they did was simply look at neuropraxic deficits across the tarsal tunnel and across the fibular head. They did monofilament testing on all these patients pre-procedure. They've done 3 applications of Wharton's jelly for these patients, right? And they're getting 12-month and 24-month data. At the 12-month mark, they ended up repeating monofilament testing, and they repeated nerve conduction velocity testing. Their preliminary data has demonstrated a 43% improvement in conduction velocity, a 42% improvement in monofilament testing, and a correlated 45% improvement in symptoms. That is pretty impressive, especially for patients with neuropraxic deficits, where we know gabapentin doesn't work, Lyrica doesn't work, nitric oxide doesn't work, alpha-lipoic acid doesn't work, at least not really well. They might work as well as placebo, but are we getting 40%, 45% reduction in symptoms? I'm not seeing it, and I've been using this stuff for 25 years. I don't see it with gabapentin. They get side effects before I can get them on enough. I don't see it with Lyrica. They get side effects before I can get them on enough. I don't even use Grelease because nobody's insurance pays for it anymore. Alpha-lipoic acid helps, nitric oxide helps, but most of my patients who have neuropathy that are men, right, they're already on Cialis or something else, so I can't give them nitric oxide or alpha-lipoic on top of the vasodilator they're already taking. So this is a fabulous option. Now, before we dive into a whole lot more, we're going to take some questions. Usually I save questions to the end, right? But Beeben, do you want to address any questions at this point in time before we move into kind of next phase?
You know, we've got a couple questions on regulatory, which I know that we would, and I'm just going to say a couple quick things so we can, because here's the thing. We have regulatory teams and attorneys that can go in and give people the proper, answers and everything. But let me just say this really quickly. One doctor brought up the Florida law. The Florida bill is a huge oxymoron because homologous use is a myth. The FDA has made a mockery of homologous use besides wound care. They've stated no flowable is homologous, but it's irrelevant because if you look in the Florida bill, cell factors are excluded. A nano DPM is not a stem cell product, which is a lot of what the conversation tonight is. Nano DPM is not a cellular product, therefore it's not in the stem cell bill. It's excluded, so you would use experimental use. A lot of other people get confused and think that biologics, somehow PRP is different. PRP is not FDA cleared to treat anything. It's not FDA approved either. And there is no indication. When you spin, and here's something, I'm a business person, okay? If you take a product that's FDA cleared to harvest blood, it's not cleared to create and manufacture a blood product in a non-sterile environment. You don't have malpractice that covers you manufacturing products. We have malpractice that individually and uniquely covers our products. But I think a lot of doctors get confused sometimes and think because PRP has a clearance for harvest, that means that magically they can use it for whatever indication they dream up when they're both experimental use. But actually, you have a $10 million liability policy with a product off the shelf versus you manufacturing a blood product and then assigning your own objective intent of indication. So I think if we just tap on that for a second, because I know a lot of people want to know about that. And a lot of doctors now are understanding experimental use and right to practice medicine. The FDA does not regulate the practice of medicine. However, I invite anyone that wants to have a further conversation with a real attorney who defends at the medical board level. Dr. Martin, you've testified at the medical board level and won multiple times. We've even overturned, and I can show you guys fully favorable with fluid flow, never sold fluid flow, flower flow. We won a $6.6 million overturn for a massive chief medical officer of the largest podiatry group over in California. So we can get into the weeds on that on another call or time, and I'm happy to set that up. But I've just if you want to just sprinkle on that for a second, Dr. Martin.
So the next phase of this is what I want to address. And this is, how do you practically do this in your office? I can talk about science for another 10 hours, and most of you are going to fall asleep. What I like to do more, right, is number one, talk about money. But number two, talk about how you can practically do this in your office right now, today, where you can make it make sense, make it make money, right, but then serve a higher purpose. Let's just dispel a few myths straight out the gate. All right, we're going to talk about this in a second, but we're going to take a sidebar. The FDA regulates human cell and tissue products as a single category. They are Section 361. All right. The FDA regulates drugs as Section 351. Now, a drug is your gabapentin, your Vicodin, your Xanax. They have a specific indication for use. Human cell and tissue product ideally has to be used in a homologous manner, right? What most people don't appreciate is that this includes PRP, bone marrow aspirate concentrate, stromal vascular fraction, A2M, platelet-derived growth factor, and Wharton's jelly or umbilical cord tissue products. They are all considered human cell and tissue products by the FDA. Practically speaking, what that means is, if I was to use any of these products and I made a claim for their use, meaning I claimed that they worked like a drug, that I could run afoul of the FDA. Now, some of you may have heard of a company called QC Kinetics. Actually, a really great company, very successful, 350 clinics. All right. I don't think they meant to do this, but in this era of regulatory enforcement, they used an ICD-10 code for their application of PRP, and they used osteoarthritis. Now, all of you as podiatrists, and I'll ask you this, Dr. Bell, tell me how many patients that you've seen with osteoarthritis of just the MTP joint and no other joint in the human body? No one, right? If somebody has osteoarthritis of the MTP, they have it right and left. They have it in the forefoot, they have it in the ankle, they have it in the knees, they have it in the shoulders, they have it in the spine. Because osteoarthritis is a systemic disease. So can I say I'm using PRP to treat osteoarthritis? Actually, I can't. I cannot make a claim that I'm using a human cell and tissue product to treat a systemic disease, because that's what a drug does. That's what NSAIDs or steroids might do. All I can say is that I'm using it to supplement a cartilage-based defect. I can't claim that any human cell and tissue product would diagnose, treat, cure, or prevent disease. This doesn't really make sense, right? Well, think about it like this. You're a podiatrist. You do a bunionectomy. Now, if you did a bunionectomy and you billed for a decompressive laminectomy of the spine, and you got paid for a decompressive laminectomy of the spine, is that what you did? It's not what you did. You coded wrong. Well, these clinics were using this diagnosis code, right, and claiming that they were using a human cell and tissue product to regenerate cartilage, to treat osteoarthritis. And as soon as you impart that biologic activity on a human cell and tissue product, you can run afoul of the FDA. And so you may say to yourself, well, I don't want to tangle with the FDA. I'm not interested in that at all, right? Great. You'll recall that just 5 minutes ago, Beeben mentioned the term experimental use. And so, again, I'm a country city boy, not the brightest guy in the room, right? Say I want to use biologics, right? Not getting great outcomes with PRP, not getting great outcomes with cortisone. I just have frustrated patients. It's not really paying me all that well to go and operate anymore, but I want to use this Wharton's jelly. Maybe I want to use nano jelly, which is cryopreserved in 70 milligrams, or this nano DPM. How can I do that in a way that complies with experimental use and doesn't run afoul of the FDA? In every one of your practices, you use something called a patient-reported outcome. Now, you may not know it, but every time you ask a patient on a scale of 0 to 10, what is your pain? You are using a validated outcome measure called the National Pain Rating Scale. That National Pain Rating Scale is a validated outcome measure that's been used in randomized controlled trials for almost 50 years. So all we did at Platinum was say, all right, now we're using donated birth tissue. Any of you that have wives that donated their umbilical cords, when they were just about to deliver, a nurse came and brought a little sheet of paper. And that little sheet of paper simply states, would you be willing to donate your umbilical cord and your placenta for research purposes? And almost every woman will sign that consent form, and their placenta or their umbilical cord is then donated to a tissue bank like some of the ones that Platinum Biologics uses. The ones that don't sign the paperwork, their umbilical cord, their placenta goes into an incinerator. Now, as far as I'm concerned, somewhere along the line, a woman donated her afterbirth for the purposes of research. And what we simply did at Platinum was we honored that sacrifice. And we created a paradigm for any of you in your practices to carry on the wishes of that mother and do experimental use in your office using patient-reported outcomes. So what we simply did was we took multiple validated patient-reported outcomes. We took an Oswestry disability. We took a San Francisco 36. We took a Womack, took a Coues, And we took a national pain rating scale. That's an R. And we consolidated all of that, which is about 150 questions, into 15 questions. And those 15 questions we internally validated in my office, meaning that I gave those questions to 50 patients, and I gave another subset of 50 questions to those 50 patients. And I said, of these 50 questions, how closely do these 15 align with how you function, what your quality of life is, what your pain is, what your sleep is, and how you feel in general about your quality of life. And when we had a 90% rate of concordance between the 50 questions and the 15, we then gave those 15 questions to 400 or 500 clinics to do observational studies and do experimental use. So practically speaking, what does that look like?
Well, Dr. Martin, I don't want to go into too far on because I know people want to go through functional application and stuff. Let's do
Sure, we'll do that.
We'll do a follow-up video on this, but guys, real simple. And I mentioned one more person mentioned the Florida bill. Stem cell products don't have tissue by nature. Okay, that's the point of it being a stem cell product because it
You want to go there?
jelly has tissue. So if just think about this, the Florida bill says it has to be minimally manipulated. You all know a product for it to be minimally manipulated and homologous use, it has to have its structural tissue to provide a structural function. That's why amniotic membrane, you take an amniotic membrane or cover or barrier, you cut it up into a Band-Aid and use it as a Band-Aid for its structural function. If you remove the tissue for a stem cell, where's the tissue? Where's the structural function? There is no homologous use. It is impossible. It is a fool's errand, and whoever wrote the Florida bill is a complete moron. But I like what it did overall. But here's the best part. All these products, experimental use, PRP, you're good to go. But if you are concerned about using a stem cell product or say a Wharton's jelly product because it's cryopreserved, then use Nano DPM. It's a dehydrated, no live stem cell growth factor product. Why did we make Nano DPM and call it DPM, dehydrated placental matrix, but also gear it towards podiatrists? Because a lot of doctors are stem cell crazy and they think stem cells are the end all be all. We know that podiatrists are mature enough because they understand amniotic membrane and dehydrate. They understand what growth factors do in the mechanism of healing and recovery. They don't need stem cells in their products because they get the foundational aspect of what you went through earlier, Dr. Martin. So anyways, we could go all night on that, and I invite you guys again to schedule, and we'll get all that taken care of. But Dr. Martin, we have the difference between stem cell and Wharton's jelly, and I think I just explained it a little bit.
Yeah, let's do that.
Yeah,
so we'll make this
and then
really
while
quick.
You're doing that, what is your interval recommendation of the while you explain it? You mentioned 3 injections. What is the
we'll go through all that.
time interval?
Let's do this really quick. The Florida bill states that you can only use unapproved products like stem cells for pain, ortho, or cosmetic use. It's got to be homologous use, meaning it has to be like tissue for like tissue. Meaning if I'm going to do an ACL rupture, I need to use cadaveric tissue from, say, a pig, right? That has the same structural function in the pig as it would in the human body. Like for like. That product cannot be manipulated. It cannot be combined with another product. I can't combine Wharton's jelly and hyaluronic acid and sell it to you. It's got to have local focal use. If I harvest porcine tendon and I apply it to the Achilles, it can't work anywhere else in the body, right? And it can't have any biologic activity. It just has to have a structural function. When we talk about stem cells, most people are talking about pluripotent stem cells. Pluripotent stem cells can turn into anything in the human body, including cancer. Most of you will remember that we cloned a sheep 10, 15 years ago, and that sheep's name was Dolly. Most of you may not recall what happened to Dolly. Well, Dolly was cloned using pluripotent stem cells, and Dolly passed away She died at the age of 5. That wasn't what killed the cloning project. What killed the cloning project is that Dolly had 5 baby sheep, and all 5 baby sheep died within a year of life because of metastatic cancer. What we are talking about is not a pluripotent stem cell. What we are talking about is differentiated mesenchymal stem cells, right? That is what is in Wharton's jelly, but we're talking about a subpopulation of Wharton's jelly that is lyophilized, meaning there are no live cells. It is just extracellular matrix and growth factors, right? In this Florida Senate bill, if you're doing something for pain or ortho or cosmetic application, right, there cannot be biologic activity. Well, if I'm using a lyophilized Wharton's jelly, there's no biologic activity because there's no live cells. It has to be minimally manipulated. Well, this is just a lyophilized growth factor complex. There's nothing else in it. Can't be combined with anything else. Well, it's just a lyophilized growth factor media with extracellular matrix. We can't combine it with anything because we don't. When it comes to you, you can practice medicine however you want. So you can combine it with saline or hyaluronic acid. You can even combine it with your PRP. If you love PRP, you can add this product to PRP to improve the growth factor delivery when you apply that biologic. Local focal use, you're just applying this locally and focally. This has nothing live in it, so it's not going anywhere. Of the products that are going to survive the Florida bill, this lyophilized Wharton's jelly is the most likely to do so because nothing else will comply at a state level, let alone a federal level. Because if I have a live cell product, strictly speaking, according to the Florida bill, right, if it's got live cells in there, there's the potential for biologic activity. Now, doctors can practice medicine. They can practice medicine anywhere in the United States. The Florida bill is a microcosm. There's a stem cell bill in Utah. There's a stem cell bill in the state of California. California has had right to try since 2017. Can you use stem cells in the state of California? Sure you can, right? You just simply have to consent the patient accordingly and let them know that it is not an FDA approved product to treat a disease. It's an FDA cleared product. All of these products, all of these Wharton's jelly products are FDA cleared, just like PRP. PRP is not FDA approved to treat anything. The plastic kit is a 510K cleared device, just like your scalpel or your hemostat. It's a 510K cleared medical device. When you add blood to that device, now it becomes a human cell and tissue product and you can't make any claims about its use. All right.
So it's
This is the
because
difference.
Cell factors, you're never going to win the argument between the state and the government. And 361 has been tortured. It's been completely ridiculousness has taken place. Wharton's jelly should be a practical cushion and support, but the FDA has run afoul of all flowables. So the best advice that the attorneys, regulatory, is experimental use. And if you want to be extra, extra cautious, nano DPM is non-cellular. It's 100% a cell factor, much like an exosome is a cell factor. And that's where you can say, I have nothing to do with the Florida bill. I'm using experimental use, and I'm also using cell factor products. I will not be the punching bag between the state of Florida and the United States government, the FDA, because they can't even spell homologous, let alone properly define it. And I'm not going to get caught up in between that. For those that have any type of issue, I know that Platinum does offer anything that free regulatory. Anything that pops up is paid for. Malpractice is additionally written in with your product. So there is more that can go on with that. But anyways, that's the last I'll say. I'll shut up.
If I could interject real quick with that for everyone's comfort level, and this is how I look at it, and sometimes it doesn't come up much in my practice. My patients trust what I tell them, and if you come with knowledge and authenticity, it comes out well and it's received well, and I do an awful lot of these. But if you think about it, is it medically safe to put someone on meloxicam for 6 months for arthritis? Is that good for their kidneys? Can that not cause a GI ulcer? I'm not going to worry about or get caught up in all this madness about something that is very healthy and works well for all these conditions that Dr. Martin discussed, especially when NSAIDs are quote unquote FDA approved. And yet NSAIDs are the #1 cause of gastric ulcers on the globe. NSAIDs can increase blood pressure. So what? A third of all our patients have hypertension. So it's better medicine to put them on an NSAID for 6 weeks for plantar fasciitis than it is a biologic. It's utter nonsense. It's better to put someone on gabapentin or Lyrica for their whole life for neuropraxia. No, it's not. So like Dr. Martin said, we are doctors. We are educated. We are supposed to practice good medicine with a high standard of care. It is a better standard of care to utilize a biologic than put someone on gabapentin from the time they're 48 years old until they're no longer here. The effect that has on the kidneys, the effect that has on their balance, the fact that it causes sleepiness, all the problems that say gabapentin can cause, all the problems that we know NSAIDs cause. And the FDA, quote unquote, has no problem with that for a lifetime of 6 or 8 or 1,000 milligrams a day of ibuprofen. But they have a problem with this. Like Beeben said, they don't know what they're talking about. We can use this product, just consent it properly.
Consent them. And another thing is, I don't think anyone's on here to sugarcoat. I hate biologics companies that tell you, oh, we figured it out. Oh, we're perfect. We've got some special sauce and we know how to lick the rear end of the FDA properly and they like us and pat us on the head. Shut up. Listen, is biologics a gray area? Absolutely. Where else can you make $30,000 to $50,000 a month in less than 90 days? With the help of Dr. Bell and Dr. Martin. I'll tell you, not very many freaking places, if any. So part of the opportunity is in the chaos. Because if everyone was willfully doing it and skipping along, you wouldn't be different than anyone else down the street either. But I will tell you, you won't find anyone that's received an infraction. You won't find anyone that's had a massive board complaint. You won't find anyone that's lost their license. You just won't see any of it. You need to do it a proper risk assessment. And is the opportunity worth it? And you just need to be an adult. You need to step back, not be fearful, and just look logically. And our job is just to give you the information to make an adult decision. A business decision is really what it comes down to. Anyways, okay, so that was my last. That is my last. Is I don't want anyone to think that we're saying it's perfect either. There are issues with biologics. There always will be. It's because they work.
Before I get into this, I'm just going to riff on Beeben's last statement. PRP is not regulated much at all by the FDA. What percent of differentiated mesenchymal stem cells are in PRP? There's exactly 0. What about growth factor complex? You only have type 1 collagen. It's also inflammatory. Now, I understand that there are a lot of people that love PRP, and I think that's fine. We have 140 randomized controlled trials just for OA of the knee in the past 20 years. Is PRP the standard of care for OA of the knee? It's not. The reason PRP isn't the standard of care and will never be the standard of care is because there is no standardized way to, number one, prepare PRP, number two, how to apply PRP, and number three, how to make it. Everyone makes their PRP different. Everyone spins it at a different rate. They spin it once, they spin it twice, right? Notwithstanding number 4, everyone's PRP is a different quality. Your blood is as healthy as you are. If I had a bucket of chicken this morning and a super big gulp of Dr. Pepper, I guarantee My platelets in my blood are not that healthy, right? There are many folks who wake up with a cocktail and a handful of pills, right? Before they have 2 donuts or 6 or a dozen, right? I guarantee their PRP is not as healthy as some of you watching this video. And for that reason, because there isn't a standardized way to prepare a PRP, everyone's is a little bit different, right? It's never been a standard of care and it's never going to be a standard of care. This is why when we're talking about a Wharton's jelly product, we're talking about standard doses, right? We don't standardize biologics based on MSC yield. You might see companies that sell based on MSC yield. Understand that the mesenchymal stem cell yield in an umbilical cord differs between umbilical cords and even within the same umbilical cord. Your MSC yield in one umbilical cord is higher further away from the epithelial layer and higher further away from bends or folds in the umbilical cord. And there can be as much as 10 to 15% fluctuation in MSCs between one umbilical cord and another. So the only way to standardize isn't by MSCs, it's by weight, dry weight of tissue, which is how Platinum Biologics standardizes their products. Nano DPM has 100 milligrams of Wharton's jelly. Nano Jelly has 70 milligrams of Wharton's jelly. This is standardized every single time you use it. You don't have to wonder if there's 100 milligrams at Wharton's jelly and Nano DPM. There is, period. Don't have to wonder if there's 70 milligrams in Nano Jelly. There is, every single time. Now, practically speaking, the application intervals that I'm using are most commonly at 0, 4, and 10 weeks. You might know PRP intervals to be 1, 2, 3, meaning a week apart. The reason that I am separating them 0, 4, 10 weeks is that we are looking for collagenous differentiation. This is the most important term in all of biologic medicine, and it has nothing to do with stem cells. Nothing. Collagenous differentiation is the process wherein the body makes collagen at a cellular level. That's all it is, right? But the body makes collagen specific to the growth factor complex present at the time. So if I have hallux rigidus and I need to make articular cartilage and I put PRP into that joint, and PRP only has one type of collagen, my PRP will create inflammation like we talked about. There will be a chemokine response. The body's own stem cells will migrate from bone, from blood, from fat, and move to my big toe. When they get there, they will go through a signaling process. That signaling process induces COL2A1, SOX9A, and ACAN to create collagen, to stimulate chondrocytes to create more collagen. Those chondrocytes can only create collagen based on the growth factors present. If I only have one type of growth factor, like PRP, where I just have collagen type 1, I'm only making collagen type 1. That's not going to help my articular cartilage much. If I'm using Wharton's jelly, which has type 1, type 2, and type 3 collagen-based growth factors, I get comprehensive collagenous differentiation. And because that process whereby the body is creating collagen at a cellular level takes some time, this is why my application intervals are separated by 4 and 6 weeks. Because there is a remodeling process there, and I need to give the body time to heal itself at a cellular level. And that is the most critical thing that I can tell you tonight. We are not injecting stem cells. We're not regenerating collagen. We are not doing anything. All we are doing is we are putting into the body a growth factor complex, the most comprehensive growth factor complex in nature, in an area that is both nutrient poor and growth factor poor, such that when the body goes through the process of creating its own collagen, as the body goes through the process of healing itself, it has the meats. It's like Arby's, it's got the meats, right? Where it can actually create that articular cartilage, that type 1 and type 3 cartilage if it's necessary. And this is why we separate out these applications.
This is the
Now,
difference too, everyone, is you're going to have a biologics company say, we sell stem cells treat osteoarthritis. And that's what they tell people, and that's what they market. This is what Dr. Martin just said is the most mature, scientifically backed. You can be judged by your peers and have scientific literature to 100% justify your reasoning and methodology. This is why we don't. I hate that stem cells are overly hyped and they think it's a miracle cure. And I think it is wrong. I think the FDA should be taking care of some of those companies that sell like that. They pressure cook patients and they just give these goofy things. What Dr. Martin just explained is what people think stem cell therapy is, but actually not stem cell therapy.
let me do this one more time. Everyone understands that.
Do a neuropraxia with Dr. Bell.
Okay.
I love
So
that one.
let's go through neuropraxia, right? And let's talk collagenic differentiation. Okay. So we have a patient that comes in and we are looking at kind of, let's put, maybe this is the lateral. So sorry, this is medial aspect. So we've got big toe, other toes. Ooh, bad ankle, right? Say this is the medial malleolus, right? Medial malleolus. All right. Tarsal tunnel lives about, if this is 12 o'clock and the heel is 6 o'clock, and this is 3 o'clock, and this is 9 o'clock, your tarsal tunnel in this scenario lives here at about 5:30. Okay. Your tibial nerve courses down the back of the leg. Your tibial nerve dives under the tarsal tunnel and splits into the calcaneal branch, the medial plantar branch, and the lateral plantar branch, right? At this region here, right, if we have a neuropraxic deficit, right, that neuropraxic deficit is a loss of type 1 and type 3 collagen. If I want that nerve where I have endoneurium, I have perineurium, and I have epineurium. And my epineurium is type 1 and type 3 collagen. If I want that nerve, which is damaged, say I have a defect in that epineurium, and these are my 3 layers in my nerve, that defect, I need to fill that defect by way of collagenic differentiation. If I don't have type 1 and type 3 collagen, what happens? Well, the body's going to scar this. When the body scars this with just type 1 collagen, do I get myelination past that point? Actually, I don't. This is why and how, when patients have chronic diabetic neuropathy, they just can't feel their feet forever, right? It's because that neuropraxic deficit, the deficit in the epineurium, has been replaced by scar tissue. Well, that makes sense because our body's own growth factor complex, most prevalent, is in our blood. It's type 1 collagen. And so when there is a defect here and inflammation happens and my body's own MSCs migrate to the region, and my MSCs have to use a growth factor soup, and the only vegetables in the soup are type 1 collagen. All I do is make type 1 collagen. But that type 1 collagen isn't what the epineurium is actually made of. It's made of a balance of type 1 and type 3 collagen. So you don't get remyelination of the nerve, you don't get saltatory conduction, and your patient continues to suffer from numbness and tingling in their feet. Now, this paradigm where we have a predominance of type 1 collagen and a discord between the balance of type 1 and type 3 collagen, does this sound familiar? What do we get in chronic tendinosis? In chronic tendinosis, we get breakdown of the common type 1 and type 3 collagen structure that's in most tendons. And because we get a breakdown in the extracellular matrix and the balance, the delicate balance of type 1 and type 3 collagen, where we get a preponderance of type 3 collagen, right? We get a chronic tendinosis. What about in chronic Achilles pathology? Again, an imbalance of type 1 and type 3 collagen. What about in chronic muscle strain? Well, every muscle fascia is type 1 and type 3 collagen. And if there's a predominance of type 1 collagen and a lack of type 3, the muscle fascicle doesn't contract and relax appropriately. Most of the pathology that we are seeing in the human body that is the result of chronic misuse, disuse, cumulative trauma ends up mostly with scar tissue, with type 1 collagen. Because the body's trying to go through collagen differentiation, but at a cellular level, it doesn't have the meats. It's like Arby's with no roast beef, right? Can't make the sandwich. All they can do is shove a bunch of bread in there. But nobody's going to Arby's to eat bread. They're going there for meat. Well, they need type 1 and type 3 collagen. This is at the heart of all application of biologics. You're not giving stem cells. You're putting in a collagen-rich matrix. You're putting in a type 1 and type 3 soup that has extracellular matrix. That extracellular matrix is the microarchitectural scaffold upon which the body rebuilds type 1 and type 3 collagen, so that when you get repair of the epineurium, you get remyelination, and then you get return of saltatory conduction down the nerve. What we see clinically is the patient feels their foot for the first time in 6 months, 12 years. What we see clinically is patients that would otherwise get a pressure sore that would end up getting infected with osteomyelitis and require an amputation, right? Now they can get off of it. What we see clinically is a patient who doesn't have a whole lot of sensation, who may have a stress fracture, right? Or who may have an early stage 1 or stage 2 sore, right? They can't feel enough to not weight bear on it, to not wear shoes that are too tight, to not walk barefoot and step on glass or step on a dog toy and rip through their foot, or further break down their cartilage, or further break down their skin. And they end up getting these infections and these chronic sores and these ulcers that you all deal with all day, every day. At an elementary level, it's a lack of type 1 and type 3 collagen. And because we're not using growth factor rich products that can perform comprehensive collagenic differentiation, we're not repairing the entire deficit. We're only doing half measures. And because of those half measures, our patients don't improve the way we would like. Dr. Bell, do you want to elaborate?
Sure. Kind of to combine what Beeben, and you touched on the science you broke down, I think is invaluable for everyone to understand, of course, and you say it in a way that I think it resonates with fellow doctors who then can translate it to more practical terms to our patients. So one thing about this specifically, and this is more like what Beeben said, we have to be doctors and we can't be afraid. Your results will be better. Your outcomes will be better treating neuropraxia. And the most common neuropraxia we see by far is sensory neuropathy from diabetes induced. So there's all sorts of metabolic syndromes that cause neuropathy. For us as podiatrists, I'm sure all of you see a few a week, if not more. I may see 10 patients, 12 patients a week with diabetic neuropathy. Here's why you can't be afraid. If you want to help your patients, if you wait for this disease to progress for years, you don't say anything first visit or second or third. You've seen Mr. Smith or Mrs. Smith now 11 times in 4 years, and now you finally bring it up. At that point, there might be so much disintegration in the epineurium, and they may just have pure numbness. They've lost all sensation. You're not giving any structure for us to work with as far as placing a biologic in there. Where they're really amenable to getting better, where you can be a doctor and get your patients better, is if you catch the patient the first 6 months, year, even 2 years of symptoms. Because at that point, they still have some structure to the outer lining of the nerve cell, the epineurium. So if something's still there to some degree at least, but they're getting these terrible paresthesias and they're getting burning and tingling. If you give them the biologic at that time, if you use Warden's jelly at that time, it has something to build upon. You can help restructure that outer layer of the cell wall, the epineurium, and they get normal nerve function back. And you are their hero because they're no longer waking up at night or not falling asleep at night because they have burning and tingling in their feet. You can't wait 10 years and be afraid when they have just complete and utter numbness. They feel nothing. That's when they're predisposed to sores and blisters and ulcerations because they have no sensation, they have no pain feedback. At that point, they're almost a lost cause. You've got to be a good doctor. You've got to be a good podiatrist, and you've got to treat these patients early on. They deserve to know that there's a way to help this condition before it gets out of control. And if you catch it early, your results are much better. I cannot emphasize that enough.
Even we've been going here for I don't know how long because I don't have a clock, but a little while. Do you want to address any questions, or do
Yeah,
you want me to?
let's bring it up here. Okay, we've got what's the name of the Facebook group? Let's bring that up. Let me pull it up. So everybody, the company that's hosting the webinar also has a Facebook group. There's actually about 2,000 doctors. Dr. Martin does Whiteboard Wednesdays. He does Protocol Power Hour. People are asking questions, esoteric cases, application, dosage, everything. We are going to send everyone a personal invitation. There's no cost. You don't have to buy anything. There's nothing. There's no pressure. We just ask that you please just conduct yourself appropriately and have respect for others. It is completely an open space for doctors not to be siloed. I always butcher the name. I don't know why I do that, but let me pull it up here right now. The Institute of Regenerative Education. There's also a certification course Dr. Martin just wrote. Dr. Martin is also publishing papers and setting up IRBs for doctors because, believe it or not, the clinical trial, which is an oxymoron because biologics aren't a drug, it actually limits, it's institutionalized to block publications for biologics. Dr. Martin is fighting back with that, with the #1 published PhD in the world, who's also our chief scientific advisor, Dr. Ashim Gupta, #1 Google Scholar published author. But join the Facebook group. We're going to send you an invitation. So I want to just knock that one out of the way. And how would you apply the nano DPM for the neuropraxia in practice?
So one thing on the Facebook group, you're going to have to put in your name, your email, who invited you, and the type of doctor. If you don't add all those, you will not be let into the group. All right. For a neuropraxic deficit, my two targets are just caudal to the fibular head and just cephalad the tarsal tunnel. Lidocaine is immediately cytotoxic to stem cells, number one, but number two, it also impairs collagenous differentiation for 2 weeks after the application. If I'm using nano DPM, all right, nano DPM again is 100 milligrams of Wharton's jelly. Typically, I'm using ×1 right and ×1 left. In this paradigm, what I'm doing is I'm reconstituting this. You can split this among 4 locations. I go a bit more potent, right? I'm using 3 cc's of normal saline to reconstitute the nano DPM. I'm putting 1.5 cc's at each locus, and I'm doing it, and this is important, extraneural. Really, I'm just doing it sub-Q, right? The common perineal nerve is very superficial just under the fibular head. It is extremely superficial at the tarsal tunnel. So I'm applying just above the tarsal tunnel where it's superficial before the perineal nerve the tibial nerve dives. And then I'm applying just distal to the fibular head where the common perineal nerve is superficial. And I'm literally just making a sub-Q kind of dump where I'm dropping all 1.5 cc's at that region. And again, my application intervals are 0, 4, and 10 weeks. I will use the same product all 3 times.
And just Dr. Martin and Dr. Bell have accumulated a bunch of written protocols, dosages, and everything else. If you do sign up for the Facebook group, the Facebook group is going to have a back office login with training. We have over 50 hours now of different stuff, different content. We're curating it all because it's been overwhelming good feedback. Now people are like, holy crap, this is all over the place. Can you bring it? We've used AI to get all of the protocols, all the applications into a bank where you can filter through everything. So we can make sure everyone has access to that as well. Make sure you check your email and join the Facebook group. Consent forms. That was another thing that was asked here, Dr. Martin. There's multiple examples of consent forms as well. Can you bill an injection code, but no materials with nano DPM? Dr. Bell, how are you doing it?
No, I don't bother with that at all. Nope. We go through when it's applicable. We talk about it. I mention the benefits of the biologic. The patient returns the next visit. I never do it same day. It's the consultation day. It's a billable visit. When it's brought up and discussed, I explain why I think it's a good pathway to go. Patient agrees. They're rescheduled the next week, whatever it might be, and I just do a straight cash payment. And that's discussed during the consultation visit, during the prior visit. And I don't get into billing anything. I don't want to bother. I keep it clean that way. And if it's appropriately consented, and the way Dr. Martin explained, we have nothing to worry about. So I keep it very straightforward. Cash only.
Dr. Martin,
nothing billed that day.
And Dr. Martin, we have some people that prefer to bill the injection. I think that's a matter of preference, wouldn't you say?
Yeah, so we do have people that, let me walk this paradigm for you, right? What we have a fair number of people do, and excuse my boxer, he's pacing.
If I can just interject real quick, Dr. Martin, and for
Sure.
everyone still listening, I do peer-to-peers with podiatrists, and the peer-to-peers are great because we end up having great dialogue and conversation, and many things that you may not even be thinking of just come up as we're just chatting. So please feel free to take advantage of that option that Platinum Biologics has to offer. It's really great, and things just naturally come up as we chat with me and you, or me and your group practice. And most of the time, by the time those Zoom calls end, the comfort level from everyone on the other end just rises immensely, because it's just great dialogue when it's just peer to peer. So please take advantage.
We do have some doctors that will bill Medicare for like a 20600 or 20610, right? And almost every MAC in the country, if you're using ultrasound or you're using fluoro, those are bundled codes. You're not getting paid extra to use X-ray or ultrasound, right? They bill insurance for the procedure, right? They are charging the patient for the biologic. So if they bill insurance, right, and whatever, 20600 reimburses whatever, $56 for say an MTP injection, right? They're getting this less their 20%. What they're charging the patient for is the biologic. Nano jelly's $150. Nano DPM's $300. This is cryopreserved. This is shelf stable, right? Not everyone wants to mess with a cryo freezer, right? Most doctors love the lyophilized. Number one, because of kind of Florida bill, but number two, they like to take this into their surgery centers. And when they're doing surgery, they like to use this nano DPM in their cases and perform regenerative surgery. This is actually one of the fastest growing uses of nano DPM. And so in this scenario, you can charge the patient, say, $500. And if you're doing this, you're going to net roughly $350, right? If you're charging $500 here, you're not going to make as much. You're only going to make $200, right? And so most of our doctors who are using this, they're charging $650 if they're using nano DPM. This is still well under the national standard for PRP, because the national standards for PRP are $500 to $1,500. Most PRP kits now are $350. The doctors that tell me that they're not paying $350 for PRP kits, they're paying $100. I say, that's true. How much did you pay for your centrifuge? Oh, I paid $10,000 for my centrifuge. Okay. Or, oh, I'm paying $1,500 a month or $2,000 a month for the centrifuge. Okay, well, the PRP kits that you're buying at $100, how many do you have to buy? I have to buy them a lot of 20. Okay, so you're writing a $2,000 check to buy those PRP kits. Are you going through those? Some of them are, some of them aren't, right? This ends up just being cleaner. You know, I had a nice conversation with a podiatrist last week, and he and I have been talking about, well, offline. We had a call probably 3 months ago, and he has a surgery center that he goes to. It's a GI surgery center, but he does cases there, and they love him because he's a podiatrist doing cases there. And they cut his max per day in one of the biggest insurances that he was taking. And so he's an owner in the surgery center, and as an owner of the surgery center, that facility fee was really why he was doing so much surgery. The pro fee's terrible, but the facility fee's hot. Well, they cut his facility fee in half for the majority of the cases that he's doing in that insurance. And so he called me up probably 2 months ago. And I said, look, I said, you're a surgeon. Why don't you consider doing regenerative surgery? And why don't you consider taking that $300 nano DPM in whatever you're doing, bunion, whatever, bad big toe, instrumented, fusion, plates, screws, whatever, add nano DPM to your surgery. And instead of charging $300, charge $1,000 for that regenerative surgery. And now you're going to make another $700 on every one of your cases.
There's an integrative chiropractor charging $8,000 to $12,000 down the street from everyone down here. And I'm not saying there's anything wrong with that. That's just a matter of fact. There is someone charging $8,000 to $12,000 down the street from you right now that you may be scared to ask for $1,000. And they're getting it. They're getting it 15 all day long. To 20.
Yeah.
We see the books.
So this scenario, I started with an orthopedic surgeon who actually was a foot and ankle surgeon, because he's in Northern California and his HMO cut his facility reimbursement over the last 5 years by 75%. They couldn't afford to keep the surgery center open. So he is now using the same nano DPM, and that $700 per case is what he's making, and that doubles his current facility fee. So now, based on the facility fee of $700 and cash $700, he's making $1,400 per case. It's keeping his surgery center and his practice afloat.
Dr.
You all are surgeons, right? As a surgeon, is this a lot to ask a patient? It's not.
It's
especially if it accelerates their recovery.
Dr. Bell, I got a question for you here. You inject proximal to the fibula head. That would almost be knee level question mark.
So you have to know your state law. In most states, it's not a problem. We're allowed to be involved with soft tissue structures distal to the knee. So you are injecting just distal technically to the knee joint. If it makes you feel uncomfortable, again, every state law is a bit different, but most states it would be fine to inject at around the level of the fibular head. I would just put my chart note, you injected just below the knee at and around the fibular head is perfectly fine. As far as scope of practice. If it makes you feel uncomfortable, which it shouldn't, I would say, again, I'm obviously very proactive with this. If I catch patients early, which I often do, a good chunk of my patients have symptoms just plantar aspect if I catch them early. So in many cases, I only have to do the posterior tibial nerve at the level of the tarsal tunnel. I shouldn't say most patients. There are plenty of patients that I have because I discuss it early on in the process. Usually neuropraxia, if it's from diabetic induced neuropathy, more often than not always, more often than not, they start off with symptoms on the plantar aspect of the foot. So if their symptoms are just plantar, you don't even have to worry about the superficial peroneal nerve. You can just do a tarsal tunnel injection. If their symptoms are plantar and dorsal, then you want to hit the superficial peroneal nerve, like Dr. Martin discussed. And again, just put into your note that you applied the Wharton's jelly just distal to the knee at or around the fibular head to infiltrate the area of the superficial peroneal nerve. Perfectly fine, barring any more kind of strict state laws. I practice in Delaware. That's not a problem at all. I would gather an overwhelming majority of states across the country. You have to know your state laws that would not be a out of scope for our practice.
And if you need help obtaining any type of letter or something from an attorney, this is once again what we back people up. Look, we have Dr. Bell and Dr. Martin. They have calendars. You can book a peer-to-peer at your leisure. We also have attorneys, practice affairs, and everything else, malpractice, at your disposal as well. I know we've been going quite a while now. So Dr. Martin, did you have any last? I know we have a couple more questions that just came in here again. We're gonna send everybody a calendar to get on with Dr. Martin and Dr. Bell, so you can talk to whomever you want based on this interaction. Also, there's gonna be a company-based one. We're gonna send 3 calendars. You can have at it, and then if you want to book an attorney to get in more legal stuff, if that's more what you're trying to do, we'll have that option. I have to coordinate that a little bit more. But please join the Facebook group. I answered some questions and I put the Facebook group in the answers. So make sure you join that. You'll be able to see all of our updates. You'll see more of these. We have 10-minute 20-minute versions of this every week, every freaking week. So with that, we could go on forever, and I gotta let these guys head out. So, Dr. Martin, you got your last wrap up before we say goodbye?
Yeah, what I'm going to say is this. At the end of the day, again, I'm a needle jockey. That's all I am, right? And all of you are surgeons. And I don't mean to be hard about this. Podiatrists were always renowned for being probably the most interventional specialty who also made the most money. Many of you destroy cash. But many of you now are losing patients to nurse practitioners and to PAs and to integrated chiros, because nurse practitioners and PAs and integrated chiros were very, very early adopters for this type of stuff. Integrated chiros were the earliest, naturopathic doctors, right? The penetration for biologics in the US marketplace is relatively small. There are only 30,000 doctors across the country that are even using PRP. Biologics, meaning umbilical cord derived biologics, is even less. So if you think you missed the boat, you didn't. You're still an extremely early adopter, right? But my encouragement is to lean in. This is where everything's going. Within 2 years, nobody will use PRP. Within 2 years, you won't be the only podiatrist using biologics for a lot of these paradigms. And so you can either lead your community by leaning in, or continue to see patient creep, where those patients are creeping out of your practice and going and seeking other alternatives. And the more time that you lean in, the more this language will make sense, the more this common sense application will make sense. And you will be standing here talking, at night to your colleagues about your results and about the amazing clinical outcomes that you're getting. Because at the end of the day, that's what all this comes down to. The money's great. Being able to afford nice things and go on vacations, that's great. The ability to, put a parquet wall or a fountain in your office, that's great. The ability to open up a second facility, that's great. To hire a nurse practitioner or another podiatrist, that's all great. But all of that is on the back of getting superlative patient outcomes. And patients aren't getting those outcomes with NSAIDs and with steroid shots and with PRP, but they are with this.
And there's an outcome guarantee we forgot to mention. If you don't get 50% or better on measure, you get free product for reapplication, by the way.
Yep. So if you use these biologics and you do a series of 3 applications, and for whatever reason the patient doesn't get the outcome that you expected or the patient expected, jump on a call with me. We'll review the case together and see if there might be some nuance that might have been missed. And Platinum will donate product until you get the outcome that you want and the patient gets the outcome they want. And that doesn't exist in this space.
All right. With that, everyone, we want to thank you so much. Dr. Bell, thank you so much. And thank you for always be open and willing to share your calendar with everyone. We'll make sure that everyone has that. Dr. Martin, as always, it's been a real treat. Thank you, everyone, from the IORE and our Platinum sponsor, Platinum Biologics. And with that, have a wonderful night. We appreciate all of you, and we look forward to earning the opportunity to be in business with you. Thanks. Good night.
Have a blessed night.